Hello everyone, welcome back to my YouTube channel My Cup of PT. I'm back with another video on scapular dyskinesia. So starting with the definition. Scapular dyskinesia is an alteration or deviation in the normal resting or active position of scapula during the shoulder movement, and it is also known as sixth scapular syndrome. S in the sixth scapular syndrome stands for scapular malposition, I stands for inferior medial border prominence, C stands for coracoid pain and malposition, and D stands for dyskinesia of scapular movement. So, coming to the signs and symptoms, patient will complain about the pain and tenderness around the scapula when using arm overhead or carrying heavy objects with the arm at side. There will be snapping or popping sensation around the scapula with shoulder movements. There will be loss of strength with shoulder and arm use. Asymmetrical posture will be seen in the patient. Usually the affected side will sit lower than the unaffected side. Winging of scapula is also a common sign seen in patients with scapular dysfunctions. Instability of shoulder will be there in patients. Patient will tell you that it seems like that their scapula is popping out. Okay, now I will be covering the Kibler classification for the scapular dysfunction. There are three types of classification covering the type 1 or inferior dysfunction. The primary external visual feature is the prominence of inferior angle as the result of anterior tilting of the scapula in sagittal plane. So there will be the anterior tilting of scapula in sagittal plane. Because of that only the inferior angle will become prominent. Coming to the second point, inferior pattern presentation is better visualized when the patient is in hands on hips position or during the eccentric lowering from overhead elevation. So if a person want to assess the patient, so patient should be kept in hands on hips position, or a patient should be told to do the hand lowering from an overhead elevation position so that we can see how much the inferior angle is prominent in that case. So covering the third point, according to Kibler, type 1 pattern is most commonly found in the patient with the rotator cuff dysfunction. Those who have rotator cuff dysfunction, this type is very common in those patients. Next is the type 2. Type 2 is also known as medial dysfunction. The primary external feature is the prominence of entire medial scapular border. And for assessment purpose, the patient will be kept in the same position as we have already studied in the type 1, that was hands on hips position, or patient will be asked to do eccentric lowering up from a overhead elevation. So coming to the second point, medial pattern dysfunction is most often occur in patients with GH, that is glenohumeral joint instability. And if you remember that type 1 was basically in those patients who have rotator cuff tears. Okay. Now coming to the third one. Third one is the superior dysfunction, that is characterized by the excessive and early elevation of the scapula during the upper extremity elevation. So there will be a hiking movement of scapula during the upper extremity elevation. This pattern has been referred to as a compensatory shoulder hiking or shrug, and it is most often seen in patients with a rotator cuff dysfunction and deltoid rotator cuff force couple imbalances. So this is all about the types of the scapular dysfunction that we have studied, and this classification is known as Kibler classification. Okay, so that's all for this video. In another video, I will be discussing about the diagnostic procedures as well as the special tests that a physiotherapist can perform on the patients to diagnose the scapular dysfunction condition. So I hope this video was helpful for you guys. If it was, please hit the like button and do subscribe my channel for the upcoming videos. Thank you.